Okay, we're going to be talking about Chapter 22, Medications Affecting Coagulation. The objectives for this chapter explain the importance of homeostasis, describe the types of disorders for which coagulation modifier drugs as prescribed, identify the primary mechanisms by which coagulation modifier drugs act, categorize coagulation modifier drugs based on their classifications and mechanism of action, identify representative drugs and explain their mechanism of drug actions, primary actions, interactions, contraindications, precautions, and important adverse effects. Homeostasis, a complex process involving multiple steps of any clotting factors. So what you're going to have, this is called a coagulation cascade. So what you're going to have is you're going to have actual injury to the tissue. It's going to release that thrombin, which is going to activate the platelets, which are going to adhere to the injury, which is going to cause the clotting to occur to stop the bleeding. So there are two factors that are essential to clotting. This is your thrombin and your fibrin. Normal blood clotting occurs in about 6 minutes. Tissue ischemia necrosis occurs distal to the arterial thrombosis. So if you have an injury or a clot or something going on, say like behind the knee, in the popliteal area, then anything below that from your knee down to your feet and toes is going to have that tissue ischemia necrosis unless you get that blood circulation back and running again quickly. Okay, parenteral anticoagulants. We're going to talk about heparin first. Therapeutic uses to treat disorders necessitating prompt anticoagulant activity. Adjunct for clients having open heart surgery or renal dialysis, as well as thrombolytic therapy for acute MI. Low dose therapy for prophylaxis against postoperative venous thrombose and treat disseminated and intravascular coagulation or DIC. And then it also can be given as a low molecular weight heparins, and that would be more your sub-Q injections. Okay, heparin complications, hemorrhage due to heparin overdose. So we need to monitor the PTT. Normal PTT is 25 to 40 seconds. If you're doing therapy, then they want 1.5 to 2 times that time, so it would be 60 to 80 seconds. Then hit heparin-induced thrombocytopenia. Normal platelets are 150,000 to 450,000. If it's less than 100,000, then you need to hold it and call the doctor. They can have a hypersensitivity reaction. You may do like a low dose, small dose, give them a little bit of heparin to see if they have any sensitivities. What would show up is chills, fever, urticaria. Toxicity, you can give protamine sulfate to help counteract that, and the effects are going to last for 2 hours afterwards. Nursing considerations, baseline vital signs and lab values, check with another nurse. Continuous IV needs a pump. Monitor PTT every 4 to 6 hours. Administer subcutaneous and apply pressure for 1 to 2 minutes afterwards. Instruct the client to monitor for signs of bleeding. Avoid over-the-counter medications because there's a lot of those herbals that can increase bleeding. So ginkgo biloba, garlic, ginger, just to name a few. Advise your clients to use electric razor and a soft toothbrush. Okay, complications of Lovenox, hemorrhage. Monitor vital signs and platelet count. Make sure you observe for bleeding, increase heart rate, decrease blood pressure, bruising, petechiae, hematoma, black tarry stools, avoid any aspirin or other anticoagulants. Neurologic damage, so you're looking for hematoma formation during a spinal or an epidural anesthesia. So look for swelling, redness around the insertion site, monitor your sensation and movement of the patient's lower extremities, and then if there's any deficits, make sure that you notify the physician. Thrombocytopenia, once again, monitoring your platelets. If it's less than 100,000, make sure that you notify the physician. Toxicity, you can give protamine, once again to counteract the effects of the medication. Nursing considerations, reinforced teaching regarding self-administration, subcutaneous injection, rotate sites, do not rub the site for 1 to 2 minutes after injection, do not expel the air bubble, instruct the clients to monitor for bleeding, and avoid over-the-counter medications such as any herbals, and then advise your clients to use an electric razor and a soft toothbrush. So for the whole classification, you're going to contraindicate it for thrombocytopenia and uncontrolled bleeding, surgery of the eye, brain, spinal cord, lumbar puncture, and regional anesthesia. Precautions, hemophilia, increased capillary permeability, dissecting aneurysm, peptic ulcer disease, uncontrolled hypertension, hepatic and kidney disease, or threatened abortion. Interactions can be antiplatelet agents. Okay, talking about warfarin or Coumadin, which many of you are probably very familiar with if you're a med aid. It is an antagonist to vitamin K. It prevents the synthesis of 4 coagulation factors, 7, 9, and 10, and prothrombin. Therapeutic uses, it prevents venous thrombosis, pulmonary embolism, arterial fibrillation or prosthetic heart valve, prevent recurrent MIs, transient ischemic attacks, your TIAs, PEs, and DVTs. Okay, complications, your PT/INR. So your labs for this, your PT's levels need to be 18 to 24 seconds, and then your INR levels 2 to 3 is what the doctor would like. Your antidote to this is going to be vitamin K. So complications, hepatitis, so monitoring your liver enzymes, toxicity. This is when you're going to give vitamin K to promote the synthesis of these coagulation factors. And if vitamin K cannot control the bleeding, you need to transfuse fresh frozen plasma or whole blood could be necessary. Contraindications, pregnancy risk category X, breastfeeding, thrombocytopenia, and uncontrolled bleeding, surgery of the eye, brain, spinal cord, lumbar puncture, and regional anesthesia, vitamin K deficiencies, liver disorders, and alcohol disorders because of the liver, because the liver is what makes all our clotting factors. Precautions, hemophilia, dissecting aneurysm, peptic ulcer disease, severe hypertension, hepatic or kidney disease, and threatened abortion. Okay, interaction, heparin, aspirin, non-aspirin antiplatelet drugs, glucocorticoids, sulfamides, acetaminophen, centodyne, parental cephalosporins, phenobarbital, carbamazepine, rifampin, phenytoin, oral contraceptives, and vitamin K. Excessive intakes of foods that are high in vitamin K, and over-the-counter medications and herbal supplements. So green tea, ginkgo biloba, garlic, ginger are just some of the types that you want to avoid. Okay, once again, monitoring PT and I should say INR levels. You need to take 1 week or more to reach the therapeutic INR. Baseline lab values need to be performed. Anticoagulant effects can take anywhere from 8 to 12 hours, with full therapeutic effect taking several days. Anticoagulant effects can persist 5 days after discontinuation. Advise to avoid over-the-counter medications and alcohol. Try to use non-pharmacological measures. Surgery, they're going to discontinue several days prior to that procedure. Okay, then your next one is direct thrombin inhibitors, so Pradaxa. It's going to directly inhibit thrombin, thus preventing a thrombus from developing. Therapeutic uses, prevents stroke or embolus in clients who have atrial fibrillation without valvular heart disease causing it. Complications can be bleeding, so you need to, there's no antidote for this, so you may have to give dialysis or injections for recumbent factor 7A or factor 9 complex to help. Clients that are going to undergo elective surgery should stop this Pradaxa before surgery as well. GI effects, the nausea, vomiting, esophageal reflux, ulcer formation. They can use a proton and pump inhibitor, such as the omeprazole, or an H2, which is your Ratidine or your Tagamet. They can take this medication with food as well. Contraindications, pregnancy risk category C, any active bleeding or allergy to the medicine, obviously, liver or kidney impairment or risk of bleeding. Interactions, rifampin or other thrombolytics and anticoagulants. Nursing considerations, oral tablet capsules take with or without food. It is a rapid onset. Use the medication within 30 days of opening it, and then no coagulation monitoring is done with this medication. Then your direct inhibitor of factor XA, this is your Xarelto. Directly by inhibiting the factor XA, therapeutic uses are going to be your arterial fibrillation, prevention or prevents DVTs and PEs, undergoing hip or knee arthroplasty, or non-valvular atrial fibrillation. Complications, once again, bleeding. So GI, GU, cranial or retinal or epidural bleeding following the removal of the epidural catheter. There is no antidote for severe bleeding, so they may have to use dialysis if ineffective in removing the medication from the bloodstream. So they can do this by active charcoal, can help prevent any further absorption. So monitor your H&H, so your hemoglobin and hematocrit. Removal of the epidural catheter can take place at least 18 hours following the last dose. So wait 6 hours after removal of administration to start this medication, to start the Xarelto back up. Also, Eliquis is another one under this list as well. Elevated liver enzymes and bilirubin can occur. So liver enzymes, your ATL, your AST, or your GGT, you need to monitor. Clients that have moderate to severe hepatic impairment should not take Xarelto. So you definitely want baselines of these labs. Pregnancy risk category C are contraindications, allergy, active bleeding, severe kidney impairment, moderate to severe liver impairment. Precautions, anticoagulants, antiplatelet medications or fibrinolytics, mild liver or moderate kidney impairment. Interactions, erythromycin, diltiazem, verapamil, quinidine, amiodarone, rifampin, carbamazepine, phenytoin, and St. John's wort. Nursing considerations, they can take this with or without food, the same time every day, and monitor hemoglobin, hematocrit, and liver and kidney functions. Okay, then you have your anticoagulants, which are your aspirin and clopidogrel, which is Plavix. It's going to prevent platelets from clumping together by inhibiting enzymes and factors that usually lead to arterial clotting. It's going to inhibit platelet aggregation at the onset of clotting process and alter your bleeding time. Uses, we're going to do primary prevention of acute MI, prevent reinfarction, and then prevent ischemic stroke or transient ischemic attack. Aspirin, it has the GI effect, so a lot of times you'll see Aspirin being given as an enteric coated, so it is not as harsh on the belly. Then hemorrhagic stroke. So you need to observe for weakness, dizziness, headache, and know your patient's history. Prolonged bleeding time, gastric bleeding, and thrombocytopenia all go together, so you need to monitor the bleeding time. Some doctors do, some doctors don't. It just depends on what physician you're seeing and how often they're going to monitor bleeding time. Monitor for gastric bleeding, such as your coffee ground emesis or bloody tardy stools. And then bruising, you're looking for monitor for bruising, petechiae, and your bleeding gums for your thrombocytopenia. Tinnitus and hearing loss, they can have the ringing in the ear or the hearing loss due to the aspirin, so they need to know that by their physician if this occurs. It's a pregnancy risk category D, bleeding disorders and thrombocytopenia. Do not give to children or adolescents who have influenza or chickenpox due to the risk of Reye syndrome. Precautions, peptic ulcer disease or severe kidney or hepatic disorders, and then older adults. Interactions, other medications that enhance bleeding, urine acidifiers, beta blockers, corticosteroids, and caffeine. Nursing considerations, low dose aspirin can be prevented, MI, and reinfarction. Notify the provider of any aspirin use. Then Plavix. You have action is acute coronary syndromes. Complications can be bleeding and GI effects as well. So bleeding, prolonged bleeding time, gastric bleeding, thrombocytopenia. So you need to monitor for these things. If they have a cath and they're on a cardiac catheterization, then you need to have access to that site and apply pressure so they don't bleed. And then your GI is diarrhea, dyspepsia, and pain, which is more your heartburn. Contraindications, pregnancy risk category B, bleeding disorders, thrombocytopenia, peptic ulcer disease, and intracranial bleeding. Precautions, hepatic ulcer disease, severe kidney or hepatic disorders, breastfeeding. Interactions, other medications that enhance bleeding, proton pump inhibitors. Do not use with aspirin and discontinue 7 days prior to elective surgery. Okay, then you have thrombolytic medications. So everything that we've talked to you about up to this point, this does not, once your clots occur, they cannot break them up. They cannot remove the clot. They are just going to prevent more from occurring. So now talking about your thrombolytic medications, which is TPA, tissue plasminogen activator or activase. This is going to dissolve the clots that have already formed. So therapeutic uses: treat acute MI, treat massive pulmonary emboli, treat acute ischemic stroke, restore patency to central line catheters. So we can, if there is an IV site that has formed a clot in it, we can use it, and we have used it to dissolve the clot in that, so we can use the IV site. Complications, bleeding. This is serious. Sites, internal bleeding are your GI, GU tracts, cerebral bleeding. Superficial bleeding are your wounds, your IV catheters, insertion sites. So you have to be careful with these patients, because now that we are thinning the blood, dissolving these clots, they are going to be more at risk for bleeding. Contraindications, pregnancy risk category C, prior intracranial hemorrhage, structural cerebral vascular lesions, or active internal bleeding. Contraindications, continued significant closed head or spinal trauma within the past 2 months, acute pericarditis, bacterial endocarditis, brain tumors, severe hepatic or kidney disorders. Precautions, severe hypertension, cerebral vascular disorders, recent GU or GI disorders, or major surgery within the past 10 days, or older adults. Interactions, or other medications that are going to enhance bleeding. So your nursing considerations are going to be to administer within 2 to 4 hours after the onset of manifestations. Document baseline platelet counts, hemoglobin, hematocrit, PTT, PT-INR, and your fibrinogen levels. Baseline vital signs, continuous monitoring of hemodynamic status, and minimize bruising, bleeding by limiting venous puncture and injections. So this is when you want these people to have central lines, or some side of line that we can draw from, because then that's going to save them a puncture. The other thing I want to talk to you guys about really fast is hemostatics. This is used to speed clot formation or to limit bleeding from a surgical site, is what hemostatics do. Also, nursing considerations, after any injection, may have to hold pressure for up to 30 minutes. Following thrombolytic therapy, administer heparin or aspirin, administer beta blockers, and administer your H2 antagonist or a proton pump inhibitor.